Hello, my name is Mallory Mandel and I'm a third-year pediatric resident at MGHfC. Today I'll be presenting the video abstract for our quality improvement project performed in collaboration with pediatric nephrologist Dr. Wei-Chen Tan, as well as pediatric pharmacist Anthony Vecchione and Jason Ciaramitaro. Our project is called Implementation of Project Ninja, Nephrotoxic Injury Negated by Just-in-Time Action in the MGHfC Pediatric Intensive Care Unit. Acute kidney injury is a rising complication among hospitalized children, occurring in almost one-third of pediatric patients during the first week after ICU admission. AKI is associated with short-term outcomes such as longer hospital stays and increased mortality, but even if patients recover from this isolated event, studies have shown that AKI is associated with long-term renal sequelae, leading to hypertension and chronic kidney disease. 86% of non-critically ill children are exposed to at least one nephrotoxic medication during hospital stay, yet no surveillance system is in place for this common cause of AKI. We conducted a quality improvement project implementing Ninja, a well-studied pediatric AKI screening tool established in 2011, into the MGHfC Pediatric ICU between October 2020 and April 2021, and compared outcome measures to 6-month pre-Ninja data. Our pediatric pharmacists would screen patients daily for high-risk nephrotoxic medication exposure, defined as either at least 3 or more nephrotoxic medications within the last 24 hours or at least 3 days of aminoglycoside exposure. If children met criteria, the medical team would be alerted on rounds by the pediatric pharmacist, and serum creatinine monitoring would be recommended for at least 2 days after high-risk medication exposure. Additionally, the pediatric pharmacist could recommend alternative medications, a shorter duration of treatment, or discontinuation of the nephrotoxic agent altogether. As shown on the graph on the left-hand side, our high nephrotoxic medication exposure rate decreased from a mean of 36.4 to 7.05 per 1,000 patient days when comparing pre- and post-Ninja implementation. Our AKI prevalence rate also decreased from a mean of 3.22 to 2.41 per 1,000 patient days, although this did not reach statistical significance, most likely related to our limited numbers. Our serum creatinine monitoring did increase post-Ninja implementation, and thus many children who met high-risk nephrotoxic exposure were not accounted for, and potentially some pre-Ninja implementation AKIs were missed. In conclusion, by implementing Ninja at our pediatric center, we were able to successfully screen for modifiable AKI risk factors and decrease high nephrotoxic medication exposures by 81%. We are excited to share that Project Ninja is now a part of our pharmacy acuity scoring on Epic, and we'll be rolling it out on LSN 17 and 18 this fall.